It is my distinct pleasure to introduce Dr. Steve Taplin today. Steve and I actually know each other through multiple outside social networks, shall we say. We'll just leave it at that, but it's really been exciting to learn about the work that Steve is doing at NCI on the issue of teams. I know we all, from a workforce perspective, are really interested in whether teams will change not only productivity, but worker satisfaction and effectiveness and quality. But we often have a difficult time grappling with the measurement of change on that front. It's a rather ephemeral, if sort of very timely and important topic, but difficult to measure. So Steve has done a lot of work in this area, and so we're particularly interested on what that means in terms of workforce planning and development. Steve is currently the Deputy Associate Director of Healthcare Delivery Research at the National Cancer Institute at the National Institute of Health. He's an internationally recognized expert in the field of cancer screening. He completed his family medicine residency in Rochester, New York, and completed a fellowship, the Robert Wood Johnson Fellowship in Seattle in the mid-'80s. His research career was built largely around his day-to-day practice as a primary care physician and the leader of a breast cancer screening program that served 100,000 women in an integrated health plan in the Northwest. He's been conducting research funded by NCI for most of his career and has more than 150 publications in peer-reviewed journals, including work on determinants of mammography use, factors affecting mammography interpretation, costs of cancer care, and the evaluation of screening implementation. Steve moved to the NCI in 2003 after being a senior investigator at the Center for Health Studies and professor in the Department of Family Medicine at the University of Washington. His responsibilities as the Deputy Associate Director include overseeing research on cancer screening implementation and the development of the scientific core of HDRP, the acronym for his division, where he continues to consider the link between the processes and outcomes of care, teams in healthcare delivery, and cancer screening. So welcome, Steve. We're really honored to have you here.
It is fun to be here, and I look forward to having this be a discussion, and I really do. If I don't get through my presentation, I don't think it'll hurt you. So if you've got questions, I would rather entertain the questions and dig in and talk about it than make sure that I get through all of my PowerPoint. So stop me when you don't understand what I'm doing or what I'm talking about or want to know more. And maybe I'll know more, and maybe you'll know more, and we both will learn something. So it is about teams in cancer care, and so I'm a family doc, but I have worked around cancer and done cancer screening stuff all of my career, and for me, it just makes the problem a little bit simpler. There's plenty of ways to make it more complicated, and I think the issue is how do we get it simple enough to be able to study it and work on it. So for me, working within the realm of cancer just makes the problems a little bit clearer and maybe some of the solutions. So I've always worked in cancer, as it turns out. And the goals, what I wanted to do here was talk with you a bit about the challenges and opportunities in cancer care. So some of what we learn and what we can do, talk about cancer care as a multi-level context, so talk about the care system as a multi-level context, and then get beyond and teams being one part of that multi-level context, and then move beyond the sort of rhetoric around teams to explore a little bit more, what do we really know about teams and teamwork? And so that's what we'll do. I think it's pretty clear that the burden of cancer is growing. The incidence of cancer is rising overall, and with the exception perhaps of some multiracial people who the population is so small it's been hard to measure, but it's not rising so much in them. But overall, the total rate of cancer is rising, so we're going to see more burden from cancer. But it's also true that the burden of cancer survivors, so we've got success to talk about within cancer. We've been able to develop medications and find things early enough to treat them that we now have a growing population of cancer survivors. So we will have, over in the next 10 to 20 years, huge populations, 22 million people at some point where we will get to cancer survivors. So how to deal with cancer and think about cancer is, I think, going to be important no matter what you do. If you talk to the oncologists, they are particularly panicked because the growth, if you talk about the population overall, the growth rate in the population is expected to grow by about 40%. The number of people that have been affected by cancer is expected to grow by about 40%. The number of oncologists is expected to grow about 25%. So we're in for, the oncologists are quite motivated to share at this point. They've got to figure out ways, and we've got to figure out ways to do things together. And so so teams, I think, are part of that, and we, in fact, working with Suana. I was on the phone with Suana this morning, and the ASCO group, thinking about teams in cancer care directly. So that's an effort we're actually doing together right now. But there are other things that are exciting in cancer too. There's new therapies coming on. There's a lot of new therapies coming forward. Precision medicine's becoming a major force, and there is a lot of rhetoric, but there's actually some substance as well. So there are things like melanoma, where we can actually do very specific things to change people's lives and to do things which get very close to cure, when melanoma used to be a fairly deathly disease. So, and these, build on our expanding understanding of immunology, and there's a lot that we're learning. We are learning what lymphocytes do. We're learning what total body irradiation, we can do total body irradiation and chemotherapy, but we're moving away from that and beginning to get very focused kind of radiation therapy. We're learning about T cells and how we modify T cells. We're learning how to combine these things. So we are learning a lot of stuff about cancer therapy, and I think the future for treatment in cancer is really very, very exciting. And it's in part because of the stuff that we fund at NCI to understand cells and cell-to-cell interactions, and what exactly it means to control a cancer cell, and what exactly it means for a cancer cell to be out of control. So it's very, very exciting. And you can go out to conferences and you can hear lots of people talking about that excitement. But you can also go out and turn the page and say, wait a minute. Back in this year, in 2013, there was or not this year, I guess it's now 2013, it's a few years back, a couple years ago, there was a publication from the Institute of Medicine saying, basically, we're in a crisis. The system is in crisis. Well, the interesting thing about that is that, in fact, they've been saying that now since 1999, where they were talking about the need to build a better health system. They talked about crossing the quality chasm, where we're not connecting what we know to what we do. So there is a long history of we're in crisis and we have a problem in our healthcare system. So while there's all this technical stuff going on, there's also this disquieting undercurrent of what's the process? How are we taking care of people? Are we really doing what we need to do? And so, as I noted, in 1999, for many Americans with cancer, there's a wide gulf between what could be construed as the ideal and the reality of their experience with cancer care. Now, have any of you had family with cancer? Yeah. Any of you have experiences that were completely satisfactory? Everything went as planned?
Almost.
In England?
Very nice. It was in England? It was in England. So anybody had that experience in the United States? No. So it really, my sister died of breast cancer a year ago, and I at the end of that, I missed my sister, but at the end of that I said, what does anybody do who doesn't have a doc in their family to get them through this system? It's like, how can that be? So it's an anecdote, but it's an anecdote that has now, a book saying that's true for many, many people. It's a very complicated system. And part of the challenge is that care is complicated. There are lots of parts. So if you think about the care system and think about how we work, about what exactly involved, it's very, very complicated. You can talk about finding people at risk out in the population, and who are they? Are they coming in? Are they getting access? You can talk about how you want to talk with them about primary prevention and change their diet, and that's going to affect their health. But you've got to get them in sometime. If you're going to talk about screening, you've got to at some point get them in to get screened. And once you get them screened, you've got to get them followed up if they have an abnormality. And if their abnormality turns out to be cancer, you've got to get them connected to the cancer system. And each of those steps involves multiple people, multiple institutions, a new body of knowledge for the patient and their family, and a big risk that they won't make that step, or that step will not go smoothly. So I think it's the complexity of our system and the fact that it's multiple players that makes part of it. And it's interesting to me that in the room, the one person who's had a near satisfying experience was in some sort of integrated health system, the UK, which the UK is actively trying to destroy, actually. So there are huge opportunities for us and for places like this to improve this experience. I think the other part of the complexity is that that experience, that those processes occur in something that for me is easier to think about as a multi-level context. Because as a provider, so I was in practice for 25 years. When I add up all the years, 25 years in medical school and 20 years in practice and 10 years at NCI, and it's not biologically possible. My wife assures me that it's true. It's possible. But the bottom line is that when you, as a practitioner, thinking about the system, I can think easily about how I take care of the individual patient, and you can think about how I work with the people around me, and I can think about how the organization in which those people are working makes it easy or makes it hard for us to do what we need to do. And then how the community and the nation and their policies and their reimbursement policies help us or hurt us in making that helping that organization help us. So I think about the context of care as a multi-level context, each layer affecting the other, and the interaction between those layers being really important. So for me, thinking about this as a multi-level context makes it easier to separate out both what we might need to think about and what we might do. So what I would do to an individual patient and what I would do with an individual doc would be different than what I would do as an intervention with a team of docs or a team of people providing care. So for me, the multi-level context is both a way to think more clearly and a way to think about interventions and tailor your intervention, build an intervention which makes sense. So that's the way I like to think about care. Now, and there are, in fact, if you take apart the care context, there are things at each level that are different. So there are biologic and there are socio-demographic characteristics, and there are risk factors on individuals, and there are decision-making preferences. The thing that I'm concerned about at NCI is that we stay in that box. We spend all of our time in that box understanding individual brains and not thinking about, but in what kind of context. So part of the work that I've been trying to do is make the connection between what the individuals do and how do we think about research that is beyond that individual. So thinking about the effect of national policy, thinking about state policy and structure. And we've got some good examples that I'll show you. Thinking about local policy. How do the resources in the community affect what the doc can do and what their options are? You can think about how, at an organizational level, what the leadership, what the culture is, what the incentives are, how those things affect what's happening at the provider level. So it's really becomes, I think, intellectually easier and cleaner to begin to take apart this problem of healthcare by thinking about it as a multi-level problem. And I think one of the pieces that we need to think about more is this last one, the provider team. So I probably don't need to build this case, but I found it really interesting that I could easily build a case for the effect of this. You could actually find data. So do levels affect each other? Federal policy affects state policy. So this whole issue of whether or not you have Medicaid expansion, you choose Medicaid expansion or not, is actually good data. Here's a paper that's separated out. If you look at those states, and there were some who expanded their Medicaid criteria before actually the Affordable Care Act came into play, and they look at mortality in those states that have expanded Medicaid versus those that are not, the states that are choosing to not expand Medicaid, they're choosing to put their people at risk. There are mortality difference. There's clear data. There's clear data. So national policy and state policy affects people at the individual level, at the very most important outcome, mortality. I cannot believe, maybe we won't go there, but I'd be interested someday to talk about how can you not be talking about that at a state level and saying, what are you doing? But state leadership, so even if you get beyond that thing, state leadership affects communities. Delaware initiative to reduce disparities. So the state leader in Delaware, the governor of Delaware said, we're gonna fix disparities in colorectal cancer in our state. He made that choice, explicit choice. 2001, he decided to do this. And he funded colorectal cancer screening treatment for the uninsured, They did it at the state level, and he emphasized reaching African Americans. So how do we think about reaching out to the African American community? And what did they show? They showed that, I guess I don't have a pointer. Oh, there I do. So 2002 they started out. Look at the difference in screening rates. 57% among Caucasian Americans, 48% among African Americans. And by 2009 they had them exactly the same. And what happened? Mortality rates dropped. So they took their mortality routes. This is one of the few examples that I know of where they actually addressed disparities and fixed them. And it's a great example where state leadership can directly affect its citizens. Communities affect organizations. The organizations, to do that, the organizations within the cities and the states had to make a decision because they didn't have complete funding of all the evaluation of abnormal colorectal cancer screening tests. So they had to figure out how were they going to do it. How were they going to distribute that? So they did that. And they made the adaptation and handled the load. So the message being that states affect how organizations can react and what they have to do. Next level, if you go down, organizations do organization affect teams. Well, the single greater predictor of reduction in medication errors is the culture of the organization, whether or not they emphasize fixing errors and paying attention to medication errors. If they have a culture that encourages that and talks about that, they will change the number of medication errors in that, and that is the single best predictor. So that gets us down finally to teams. So how do we know whether teams affect care? And Polly has already said, we got a little bit of a problem. There's a lot of talk about teams, but do we really know how well they affect care? And there's been talk of teamwork and teams since the 1900s. If you go back and read the literature, they all talk about teams. So I found some stuff, really interesting stuff from the early 1900s talking about how teams were a solution to healthcare because there's so much to know. This is back in 1900, right? There's so much to know, we can't all handle it, so we need to break it up and we'll have individual subspecialists. So teams were an obvious way to handle the problem of knowledge and the knowledge base. I think the Affordable Care Act is actually incenting teams and teamwork. So they're incenting patient-centered medical homes and primary care. They're incenting accountable care organizations and the force to get organizations who otherwise might not work together directly to work together. So I think that teams are now back in the front line because of, in part because of the Affordable Care Act's financial incentive to actually make things happen. So what is a team? You got to have two people, right? So two people, and one of the key pieces is two people who share one or more common goals. So how many of you are providers? Right. How many of you providers ever sat down with your clinical team and said, what's our goal in care here together? Did you ever do that? No. Did you ever do that, David? You did. When did you do that? What happened?
Well, not only that, but how are we going to know if we accomplished our goal?
What happened?
We agree on that.
What happened when you sat down and said, what's your goal in care?
People hadn't thought about it, but they did. And I think there were a lot of different ideas about what it meant and whose responsibility it was, and when we could see change and what it would mean.
Mm-hmm.
So it opened up a can of worms, would you say?
Yeah. Yeah. Oh, I was splitting care, when I was in practice, I was splitting care half-time with another, because I was doing research at that time too, and I was splitting with another practitioner, and we'd been practicing together for 10 years before we sat down and said, what are we doing? And when we sat down with with the people we were with in a room, we got the whole distribution of why are you here, from to get a paycheck to save lives, help people, change the world. And so that was interesting by itself. But then we also found out that we were driving the nurses crazy because I was managing my Coumadin on Monday and Wednesday, and my buddy was managing on Tuesday and Thursday, and I'd order it on Monday and he'd get it on Tuesday, and then he'd do something different than I did. So we were driving the staff crazy because we had never, just on the very narrow issue of Coumadin, which is an anticoagulant commonly used for atrial fibrillation. You got to get it in the right place. You got to make sure that their anticoagulant isn't too big or too low, and it's a constant challenge because people do things. And so
I know you're going to probably get to this later, but the other is what disciplines we learn.
Mm-hmm.
My group, we had nurse midwives and practitioners, So that was another, not to say barrier, but another issue to talk about what we did. Because the nurse midwife said MD stands for me doctor. So I'm saying that because their perception of who had the power and what was going on, and so it's really, I think we'll get to it later, but I think
No,
it's important.
no, I don't know. We'll see. We'll see if we get there. But I think it's a really good point. It's a really important point because there's also a lot of stuff that happens in workforce and in practice where that issue of what's my role as a doc and what's your role as a nurse practitioner doesn't get explicitly addressed ever. And there's all this passive-aggressive stuff that goes on between the two people because they've never sat down and said, what's our goal here? What are we trying to do? So this issue of teams and teamwork, I would raise in medicine is the first step. And I'm not convinced it happens very often. I think David is an exception. And most people practice without ever talking about why are we here, the assumption being that they're all here for the same reason when in fact they're not. So the other piece about teamwork is they're interacting socially. They have task interdependencies. We'll talk about that a little bit more, but that's a really key piece. So task interdependencies means that the work you're doing, to be successful at whatever the piece of work is, two people have to agree on what you're doing. And so if I'm working up somebody with an abnormal mammogram, I'm the primary care doc. I've ordered the screening mammogram. The mammogram goes off is get read by a radiologist, and it's abnormal. Now, who's managing the next step? Do they tell the patient what to do, or do they come to me and tell the patient what to do? And if the patient gets it from the radiologist, do they know that it's what I want them to do? So to actually work up this person to make sure that we understand whether she's got cancer or doesn't have cancer, the radiologist and I are interdependent. We've got to be able to work that out. And that doesn't always happen. In fact, there was legislation that mandated radiologists give a written notice to the woman directly because that problem was not happening. They were not getting follow-up. Women were not learning what, in some cases, the radiologist was talking to them, sometimes they wouldn't. Nobody had talked about it. So it actually ended up in legislation to say you have to communicate directly regarding the results of a mammogram. It's one of the few places in medicine where it's actually mandated. There are problems in other places as well. So there are interdependencies. We've got to maintain and manage the boundaries, so we've got to know when we stop. They've got to be, and then in this particular definition, it's embedded in some organization. That's not necessarily always true. You can have teams that are outside of organizations, but in this case and in healthcare, most of the time they're within an organization. And I think and medical care, as we've already talked about, lends itself to working in teams, and that's why people always talk about teams. A huge amount of information to manage, way too much, way too much. You can't do it, so give it up. You've got to figure out how do you manage it. You can't know it all. Extensive differentiating of tasks and technical expertise. So, we've got receptionists, we've got people in the lab, we've got people doing treatment, we've got billing people, we've got medical records people. There's lots of different parts who are built into it, and we share that work. When we share that work, I think we have an advantage. And it turns out there's stronger, the idea of teams. So it makes a lot of sense. We should have teams, and that's why I think you see teams and teamwork talked about all the way through from the early 1900s. But the reality, the difference between actually having teams and thinking about teams and understanding them and what we actually do is quite far. There's a big gap. And I think part of it is also because of the complexity, but also because, docs, as David has alluded to, the MD, some people will say MD stands for me doc, that there's a little bit of an independent group, and in part of our training is to be that way. We end up having to make decisions that are important. You got to have confidence in that decision. You got to know what you're doing. So there is a group of people who go into medical school and they become a bit independent, wouldn't you say, Paul? Yeah. There's also individual incentives. So I think the other piece, and I'd be interested in this group thinking about it, and I think to me this is one of the biggest areas right now in medicine, is that the incentives don't necessarily drive teams. They don't necessarily, the individual incentives are for the doc. The doc is the one that makes more money most of the time when things go smoothly or go more, because you see more people, you charge more bills, you make more money. There's also huge time pressure, there's productivity pressure. you know, all of this feeds into the culture of America, which is, you know, me, I. That's the way capitalists work. And we already said that there's lots of talk. Now you can talk, and so I was intrigued by all of this and intrigued by the amount of stuff talking about teams and thinking about myself and my experience in care, and started to want to explore, what do we know, what do we really know about teams and teamwork? And so one of the biggest people that working in this area is a guy named Kozlowski, and this is his formulation of how teams work. Turns out it's a fairly simple formulation of teams and teamworks, because most of the work has been focused on a nice clean task. And even if they get into medicine, it's the task of removing a gallbladder, or it's the task of responding to a cardiac arrest in an emergency room. Fairly discrete, fairly clean, fairly clear pieces. And that fits into this kind of a model of there's a clear task, there are some demands on that, there's team processes, there's a way that people get together and think about that task, there's how well they respond to that, and then there are some things that happen around that team that affect it and affect how they work, and that feeds back into how they think about themselves and eventually into how they begin to conceive of themselves as a team, and in something called emergent states. So a way that they self-conceive of themselves and share how they perceive their work. And it turns out that if you train teams and teach them about this task and manipulate their emergent states and the factors around them, you can affect care. And there are other ways. So I think the conceptualization of teams is really important, because that's part of where we begin to think about measurement. You have some sort of conceptual organization of what it is, and then you need to think about how are we measuring those constructs. Do those constructs exist? Can you measure their effect, and can you measure what's happening and how they're demonstrated? So this is another conceptualization. This follows a fairly typical kind of thought processes of inputs, mediators, and outcomes. So it's called the IMO approach. It's a pretty typical linear process in which there are organizational and team contexts that affects the processes and the emergent states, and then that affects the outcomes. It's another way of thinking about it, also a simplification that can be helpful. But when you actually begin to get into, as Polly's alluded to, how you measure effectiveness, it gets more complicated. And you can think about three major approaches: the system resource, the internal processes, and the goal. So thinking about what's the quality of the staff, what are the costs of work, what's the resource consumption that's going on. Think about the internal processes. How is this team working? What's their spirit? What's their culture? How are they functioning? And you can think about the goal. What are they achieving? So profitability, numbers of patients seen, the quality of the service they're giving. So it's three ways to think about measurement. When I started to look and dig in, so this is nice, it's all sort of the big picture. What do we know about teams in healthcare? Turns out that most of the work has been done outside of medicine. So most of the work on teams is done in business. They have studied productivity. They've studied a lot of stuff in business. I think these are a couple of nice reviews, one by Cotton and one by Cohen. And most companies use teams in some way and talk about teams and report that they have teams. This is where we started to talk about emergent states and the relationship between the size and productivity, and identify that in fact there are sub-kinds of teams. So you could think about a work team, you could think about two teams that are working in parallel to achieve some task for the organization as a whole. Think about project teams that come and go to do a specific things. You can think about management teams that are managing the teams below them. So when you start to get into it, you can start breaking apart the purpose, the overall sort of broad category of purpose of that team, and learn something. There are also some summaries that we're looking at medical care. So West in 2002 and Lamo Charles, and I'll go into those in a second, Manzer in 2009, Bosch 2009, four big kind of nice summaries of what's going on in teams in healthcare. And in the UK, not surprisingly, the UK, and in fact in a lot of the team literature in medicine comes from countries with organized healthcare systems where they're actually thinking about teams. So West is a researcher from the United Kingdom and has looked a lot at hospitals and teams in hospitals. And he looked, found teams in every setting on hospital wards, in radiology and surgery. So teams exist in medical care. That was his point. And he's found some really interesting stuff showing that teams, in fact, when hospitals encourage teamwork, allow time, make time for teamwork within a hospital, you actually can demonstrate mortality difference within the UK in a culture, in an organization that more heavily emphasizes teams to one that doesn't. So some very interesting work that he's been doing. Well, Mo Charles is another, she's a researcher, I think a nurse practitioner from Canada, looked at all the literature from 1985 to 2004 and identified teams with a comparison group and looked at care delivery teams and project teams. She noticed that when you look across all of the work that's going on, there are three major approaches, sort of quasi-experimental design approach and field studies are the two biggest ones. There were some experimental randomized controls, but that's pretty rare. And concluded there is evidence for some improvement in clinical outcomes, some improvement in patient satisfaction, not so clear that interventions lead to effects, and not so clear and almost nothing about how, what's the relationship. So how does it do it? What does a team do? How does teamwork have an influence? So to me, that's part of what we're doing. So part of my job at NCI is to figure out where's the hole, what's missing. So to me, this is a really helpful study because it's really saying we need to understand more about the processes. How does it happen? What did teams happen? Manzer in 2009 looked at 101 studies, operating rooms, emergency rooms, intensive care, and he concluded that perceptions of teamwork and safety-relevant work is associated with patient safety. So if they just think that they're in a team and know it, then there's some evidence that they do better. And again, at the bottom line in his work is similar to Mo Charles, that we don't know how they do it. We just know that they do it. We don't know what it is about teamwork or culture that makes the connection. They also, there's another one by Bosch. He was a little more pessimistic. He really had mixed evidence of benefit. And he looked through 2008, 118 abstracts, 26 articles, and different ways of improving teams. So increasing expertise, so adding a pharmacist to a team, or increasing coordination. So, and there's a lot of talk right now about navigators. Paste a navigator on any system and they'll fix it, right? And so that's another, and in fact there's evidence out there in several other ways that adding a coordinator or navigator, whatever you want to call them, does improve care. So again, teams with increased expertise increase the process and maybe patient outcomes, and teams with can increase coordination. So there's a body of literature showing some sort of relationship between teams and teamwork, in particular satisfaction and maybe some big outcomes. Don't know how it does it, but it's there. There's also some work in primary care by Rich Reed, who was out at Group Health. So when I left Group Health, which is where I was in practice for 20 years, Rich stepped into my shoes and took my practice, and then he started doing teamwork. And so he studied what's the effect of organizing and creating a patient-centered medical home. And it's really his work that sort of inspired some of the patient-centered medical home work. And when I left, our panels were around 2,300 people, and they did a conscious move to move from 2,300 people in your panel. So panel means all the people assigned to you. So 2,300, and they shifted it down to 1,800. They created teams. They did things like a daily huddle, which means at the beginning of the meeting, or the beginning of the day, you gather and say, what are we doing today? Who's coming in? What are we doing? What are the big challenges? I see Mrs. Smith is on there. We better plan for that because you know what Mrs. Smith does. And so they sort of think about that day and organize it at the beginning of the day. And they also did things, and this is really interesting, the third bullet down, visual display. Put a physical board in the center of the practice where they could say, sort of, heads up, keep track of what things were going on. Wait a minute, Mrs. X just went into the emergency room, better be aware of that because they may be getting a call, so let's get her chart, let's do some things, find her electronic record. You can tell that I left practice right when they were putting electronic medical records in place. So I still refer to paper records. So, and what they showed was that when they created a team that did all these things, they actually improved both their patient outcomes and patient satisfaction. So compared to baseline, all these measures are almost all of them are significant at 12 months and at 24 months, and they improved the doctor-patient interaction, they improved the use of shared decision-making, they improved the coordination of care, they improved access to care, and they improved helpfulness of the staff. So all these measures, really nice, validated measures. It's a really good paper. It's a really good source of measurement issues.
Did they measure any of the sort of classed opportunities of
No.
time?
They looked at time. They looked at time, and they actually reduced time for the providers, so they could see more people. They actually relaxed it, and that's part of how they got from 1,800 to 2,300 to 1,800. They said, we can do better, and we can raise our satisfaction. That's going to raise our growth overall, so we can afford to expand. So they did some policy changes as a result of this to expand. Now they're retracting some of that now, but they were in the process of saying, we hire more people, we can do teamwork, we can pay for it, we can do better.
It's still a little strange to think about, go 2,300 to 1,800 and add staff. Like you would have thought that you stay at 2,300 and add staff and you reduce the load, or you just reduce to 1,800 and stay with the doc.
Right, right. Well, but if they went to 1,800, they didn't have enough docs. So they had to reduce their panel to 1,800, they had to expand their staff in some way. So once
So
they'd
we're
shown
using
that this,
more
yeah.
advanced practice clinicians?
I'm not sure how they did it all.
This is in a capitated system.
This is a capitated system. Yeah, this is a capitated system, I'm sorry. Yeah, this is all in a capitated system.
The other thing I was thinking about that is there are these moves now to reduce panels. And the one question is, how patient-centered is it? You know, we sort of thinking, well, that would be patient-centered, they get to spend more time, but then there's, say, like there's 500 patients that had to get a new doctor or a new practice because they were out of panel.
Yeah, oh, that's right.
So I'm not sure, I haven't heard any, sort of think about it from that perspective. What do you do with those and how to deal with those new 500 integrated new practitioners?
Yeah, well, that's a good question. I don't know if anybody looked at that.
Opposite to what we try to do is
Yeah.
patient-centered, but 500 people on, how do they move?
Yeah.
And they
So I suppose, yeah, that's a really interesting question. I don't know what they did, how they did it. I'm sure there are some people who they don't care. They're not seeing their doc that often, so they don't have an affiliation. But whether they had volunteers who would like to go somewhere else, I don't know what they did. It's a good question.
Well, also when you look at this, it could be a significant number of patients they weren't sure which panel they were on. Don't think that there were 2,300 patients that knew that the team and the patient knew that was my team.
Yeah, that's a good question.
Right?
That's a good question. Well, I think everybody, in group health, I know that everybody is given a name, whether they feel like they're actually there. That doesn't mean the doc knows they're there, that individual is there, but the patient has a name. They have a place to go. So I don't know. Go ahead.
Since we're interrupting you.
Go ahead. That's what I tried to do.
The visual display, is this like a computerized thing?
No, it's really simple.
It's like
It was a
bulletin board?
whiteboard. Yeah, it's a whiteboard.
Okay.
It's a
People just
whiteboard.
write on it.
Yeah. And as soon as I said that, I said to myself, well, what about confidentiality? Mrs. Jones has gonorrhea. We better take care of that. No, you can't be doing that. So I'm not sure what's on there. Or Mr. Jones is, you have to be careful because you got other patients going in. But it may be, so I don't know the actual physical piece, but it's a common technique if you start reading through the literature of getting it up on so emergency rooms, putting it up there so that you begin to see, everybody's seeing the same situation. There is as you probably know, there is something called situational awareness, which is part of what good teams do. How do you keep track of all the things that are going on and be aware of what's happening? And the whiteboard is the technique to address situational awareness and keep the situation in front of everybody.
So one of the things we did at the MFA and the
What
survivors.
are
Sorry, Amelia Chapman, GW Cancer Institute, GW Cancer Center. One of the things that we did when we were establishing the cancer survivorship clinic at the MFA was use a whiteboard. So the patient was coming in to see a social worker, a nutritionist, an NP, and an internist, and so just kind of having the schedule for the day and knowing that you had to get all of these patients through various providers in a certain period of time, we just had kind of who was coming in and little magnets to adjust, like, okay, well, this one's done, moving, you're assigned to them next, and there was a huddle at the beginning and all of that. So I'm not sure if, to what extent, like, what information is being shared.
How'd you deal with confidentiality? Where was the board?
The board was in the clinic where the only the providers were.
Okay. So
In a private room where the providers met with computers where they would access the medical records.
Yeah.
It wasn't in the hall.
Yeah.
It was,
Yeah.
It was
Okay.
kind of in the huddle room. So. Anyway, it worked. That seemed to work well.
All right. So then I decided to. So Reed showed in primary care, good stuff. There are some reviews of things overall, but I wanted to look in cancer care to see what was going on in cancer care, and it turns out there wasn't much going on in cancer care. So. So I pulled what we did. So I actually worked with Suanna and some others on this paper, and we started to look in cancer care and see what do we know. And so there were we went through the typical sort from 8,000 people that mentioned something about teams down to 459 who were discussed teams in some way, and 56 who actually did some evaluation. And we kept narrowed it down until we got to 16, which actually had a clear definition of a team and actually compared team care to a control group. So really pretty small amount of work. The nice thing was that made it easier to do a review and to publish. So we did that. And we distributed them across, and we looked across where were they in the cancer care continuum. So 2 of them were looking at teams in screening, 11 were multidisciplinary care teams, 2 in palliative care, and 1 at the end of life. So a nice distribution across the cancer care continuum. Most were time series, 1 randomized trial within this group. Most had a contemporaneous comparison, so now we required a comparison of some sort, and 1 had a pre-post design. Kind of soft, endpoints of adherence to quality indicators, so did they follow the guidelines? Satisfaction with care with somebody, so that was an endpoint in 1 of them. Most of them were looking at adherence to quality. Quality of life and mortality, there were actually 3 that did try to look at mortality, and a couple that looked at quality of life. And of course the team composition was all over the place. So we were across the continuum, so there were different kinds of members in the team. There were primary care led teams with a licensed practical nurse and a registered nurse. There were people in oncology, pathology, radiology. Multidisciplinary care teams had all of those. For me as a primary care doc, the interesting thing in multidisciplinary care teams was primary care doc was rarely there at a multidisciplinary care team meeting. Pharmacist-led teams were a pretty common thing. Add a pharmacist and see if it fixes things with medical errors. And the results were there was guideline adherence was improved, improved timeliness of follow-up so that they moved forward in the steps in the screening process more efficiently. The multidisciplinary care teams improved pre-op assessment, so they cleaned up their act in terms of preparation for surgery and the therapy planning and adherence to meds. So there were some things that came out of multidisciplinary care teams that were productive. Big question in my mind about multidisciplinary care teams is who is that? Because it's actually a group of people who are sort of the chiefs of teams, because each of them is working with people. They're not actually together working together to do this. They're working as the leaders of subsections who then have to work together. So there's an oncologist, there's a radiation therapist, there's other groups too who are pathologists, and each of them is sort of leading a group of people who's doing things. So the multidisciplinary care team is a really interesting team, and how exactly you measure their function and how much is it interdependent with the functioning of another team, I think is a really big question. And there's no information in any of them about how and why the connections were made.
Why do you think that's true, that last bullet?
I think it's because people aren't, that's the nature of the field. We need one.
Need more anthropologists.
We need anthropologists, yes, to study it. We need people with measurement to say, so okay, so great. What do you want to measure? What are you going to measure? So you want to measure their culture. How do you measure their culture? What do you do? And what parts of culture matter? So I think it's where the field is, and it's a great opportunity for people in schools of public health.
So I mean, you're raising your sort of very basic questions, and in my own mind, I go suddenly like, okay, what is a team? Okay, if there are 5 people and they're all doing a piece of the care, they could be all 5 independent, or they could be a team. But again, what makes it a team? So I'm curious, having done the literature review and worked on this, what do you think makes a team? Because it's not just that we're both working on the same patient, it's that we're working on the same patient collaboratively in some way. But how do you define that? How do you measure that?
That's a great question. I think that's an area we need to work, because I think there is work within teams that looks at multi-team systems. And I think the question you just asked is one of the first fundamental questions. Where is the team? So if you go back to the definition, they have a common goal. And I would bet you that if you think it's rare that a sub-team has sat down and said what their goal is, a group of teams working together, so how many times have they ever sat down and said, what are we trying to do here? What's our goal? So the radiation group and the oncology group and the surgical group and the primary care group who made the referral, I would bet you that even if all of those other teams have sat down and said their goal, and I'll bet you they haven't, they have never or hardly ever invited primary care in and said, how are we working with you? How are we serving you? How are we serving the persons what's your goal? What's our goal? What's our relationship? What should we be doing? So I think one of the key pieces is, have they set a common goal? And I would argue that if they haven't set a common goal, they aren't a team yet. And that's a fundamental problem. But that's also testable. To me, that's a randomized trial test. Have a group that sits down and works that out, works out a team, versus a group that doesn't. What happens?
So Steve Shortell has done some work on social network analysis within organizations, right? And it seems like that approach would be, particularly for large systems that have all these specialty practices within it. Has anybody done that? I mean, outside of, it doesn't have to be cancer, I guess, but it seems like that would be.
So what do you get out of that?
I
haven't seen that, although there has been work about who's working with whom. Because
when I started thinking about this, you think about a map, and you think about kind of chains of teams, and then you could think about kind of levels of teams with regard to, whether they meet these criteria that are in the definition or not. But, it's sort of it's really about understanding how communication flows across a broad system, sort of from.
I think that's true, and I think you could, I would just raise, I don't know what the answer is, Polly. I think you could raise that, you could do a beautiful social network analysis, and it turns out these people are working with these people, and these people are working with these people, and you could figure it out, and you could figure out where people go. And then I would ask, does that tell you whether or not they're working as a team or not? And I would suggest that it doesn't. It tells you who's working with whom, and it's complicated, that's for sure. But I don't know whether it tells you that you've got a team there. That's my question. And whether you need to. Maybe you don't need to. Maybe it's sufficient to have a network and work within your network.
The way they gather data is often through interviews. So you could add to the interview schedule something about, have you ever discussed goals, or whatever the measures are that you think really make a difference, and have some kind of, multicolored map or whatever.
Mm-hmm. Yeah. Well, that would be an interesting piece of work. You could start to find out, have any of them sat down and said what their goal is, just as a descriptive piece, and find out, is there any difference in terms of outcomes, of any kinds of outcomes? So patient satisfaction. There's some evidence that teams improve the satisfaction when there's a team that works together, that their patients are more satisfied. So that would be interesting. That's a potential piece.
So since we're coming up on the hour.
Oh my gosh, okay.
I know you have additional stuff, but you're identifying research gaps. We're all researchers. Is NCI funding this kind of work, or is it just you out there trying to convince them that this is really important?
Well.
If you prefer to leave this for the end, we can
No. Yeah, let's turn off the camera, right? No, there's not a lot more. Let's stop. Let's talk about it. So, so part of what happens is at NCI to develop a research agenda is you got to build an argument. And you got to build an argument that what is missing is having an effect on care. So we're kind of in that process right now. There is AHRQ, so the Agency for Healthcare Research and Quality has done a lot of work in teams and is really focused on team training. So that's what this slide is about, team steps. They're funding a little bit of work on research, a little bit of research, but not a lot. And so I'm arguing that we should be doing it. And we are trying to and we are building, so within the Healthcare Delivery Research Program, we're building that piece. But we still have to get things through review, and then we have to convince the leadership that this is worth doing. So we're kind of in that process where I think if you submitted a grant on teams in healthcare, it could get through, it may not get through. So we have not written and set aside money, so there's a stage within NCI, there are stages. So there is everybody can write anything they want. If you have a grant, though, you need to adhere it to some sort of general announcement. So at the very least, you can find a general announcement that says, we're interested in research, and you say, I have a piece of research, and you tie it to that. The next level is a program announcement in which we've said, we're really interested in something about teams. We're at that point, writing that piece now, but it's not out there yet. So there is a piece that I wrote called Multi-Level Interventions, within which there is a little section, I think, on teams, about teams in healthcare, so you could hide it in there. But we're at the point where we're trying to say, in general, we're interested in this work, and part of it is really interacting with researchers. So when you sit on a review and somebody comes in and says teams, you don't say, what? Yeah, so we're right in that process of trying to make that work happen.
You know, that first slide was sort of the ecological approach, which I think was very important. Do you think the NCI will also be open to research methods that are more mixed methods?
Absolutely, that's going on now.
As opposed to having to be an RCT, which may actually not be appropriate for the discussion that you have?
No, I think there is yes. There's much wider interest in multi-method research. I think especially when you finish with a quantitative piece of it, you do some background work, and you really listen and develop surveys and work based on real initial work, then I think there's a real strong argument and a much more open review to that kind of work.
Are there some aspects that you think are unique to cancer care in terms of team function?
It's a really good question. My instinct is no.
I mean, the composition of the team might be different, but the functionality and maybe some of the issues around relationships and communication.
That's a really good question. My hope is that there isn't. That cancer is just a unique circumstance. It's a content area, but you still need to understand in cancer how do teams interact, because if you've got cardiovascular disease, it's the same sort of situation. People with cardiovascular disease also have other conditions. They need to interact with primary care people. So there are several people can be involved. So I think my hope is that, in fact, it's generalizable. But like I said in the beginning, the interesting thing for me in cancer is that it sort of focuses things. It's just a place to keep it, one simplification.
So just something to throw in for you to simmer on as you talk about this and think about this. So one of the studies I'm working on in collaboration with researchers here at the School of Public Health is a national survivorship study looking at how care is delivered to people after they finish cancer treatment. And I think 8 years ago, my assumption was that team-based care, and so I'm going to caveat this by saying, is it a team if everybody sees the patient versus one person sees the patient, but there's other people in communication, which that might be a separate question, right? But I was under the assumption that if you had a multidisciplinary team, that intrinsically you're going to get better care than if you see one provider. And I think at this point I've evolved to wondering, well, for what patients are teams most helpful, and for what patients are individual providers potentially more helpful. And in thinking about kind of mandates for survivorship for institutions right now, from accrediting bodies, I've kind of come full circle in terms of maybe the right thing is for survivors to see an NP and have that NP be in communication with different providers, but for those patients with a lot of needs, I still think the multidisciplinary team is irreplaceable. So just kind of throwing in not only our teams the way to go and how they work, but for what patients.
I think well, there's a whole lot in what you said. I think that's fascinating. And in fact, if you look, Eduardo Salas is one of the sort of, if you start reading team literature, I don't know what he does, how he does it, but his name is on everything. Eduardo is really, really sharp guy. He's a really quick writer, and he's really thoughtful. But one of the things that he says very clearly is, there are some instances in which teamwork isn't the solution. We don't need a team. You need an individual. So knowing when the team is helpful and when it's not is important.
Efficiency and reaching as many people as possible, not necessarily intrinsically it not being a good thing, but that if you have a limited amount of resources, what's the same for a patient versus...
Right. Well, part of it gets back to the conceptualization again. So what's the task? Some tasks are going to be helped by a team, some tasks are not. So it's getting back to sorting out. And that's what I find appealing about this stuff, is that you start to conceptualize it and then you say, oh, wow, well, there is we can think about that. It's about the task. This task doesn't need it. It doesn't need a team. But then I think there was something else in what you said that was really important. The functioning. So what's the function? What's actually being asked to do? And so or that task, maybe it's the task, and then to achieve that task, what are you doing? So it may be true that a team doesn't need to meet together and talk about it.
Is it communication and role delineation, or is it working together with a common goal and everyone seeing the patient?
That's right. I think those are all questions, but that's all research. That's all the possibilities to begin to explore. What is it? One, do they have a goal? And then two, what do they do together? And to achieve this kind of task, what do you have to do together? I think being clear about that is really important, because organizations are saying, go be a team. Yeah, but I've been in an organization where you'll go be a team and there's no time to meet, and there's no reimbursement for it. You're supposed to be seeing 25 people. So when am I going to be a team? So I think that we need to be getting organizations to understand, you want to be a team, this is what it means. This is what you have to do to make this team work. And we also need to show that doing that will improve the outcomes, which I think is the other piece that's really important, more than they're happy, but that it affects costs, it affects outcomes. It's not that I want people to be happy, it's that I think to really move things, you're going to show, if you show things like that, then you can move things.
And for those of us who have a sort of a workforce lens on this, I think a lot of us, and Jung Young has done a lot of work on PCMHs recently, and it would be nice if at some point you all could connect and hear about that. But I think from a workforce planning perspective, there's a lot of interest in how teams are going to change the kinds of people we need in the future, because the demand side of projections is really hard to get. So just to sort of throw that out there is something that we're concerned about, and Ed is sort of a leader in that sort of research area. And then the other is the changing role of specific kinds of professionals, in particular nurses. Everyone understands that the role of nurses is changing dramatically, but really understanding how those roles, and the role of physicians, and the role of advanced practice clinicians, and the role of the MA, and so all the role changes and what that means in terms of who we need in the future are sort of really big questions for us.
All really important stuff. And to me, some of that stuff is more complicated if you don't think about teams. So if you're just trying to get the role right, and you're not clear about what you're trying to do, or what's the goal of this, or what's the relationship between that role and the other roles, I think you can go on trying to define that role forever, because everybody's coming into it with a different view about what we're trying to do and and how they're going to interact with other people, and they're usually bringing their views. So if I'm a doc, this is what I need. So I think that this whole role definition piece could go on forever unless you begin to put it in the context of what are we trying to achieve, and how do they interact with others, and how do they work as a team? Do we want them to work as a team? I'm just raising that as a backbone.
Okay.
Another element that I don't think we discussed is what's said to the patient about this, about either they're being in a team or not. And I've heard a lot of our members who are mostly oncologists remark that if there is sort of this among certain people this assumption that the patient will want to see the physician and they won't want to see the nurse practitioner, physician assistant, or someone else on the team. But a lot of the people I talk with say if they go in, to that first meeting with the patient and say, especially people in academia who may only have clinic a couple times a week, and say, this is my nurse practitioner or my physician assistant, and they will be seeing you along with me. If they introduce that concept up front, then the patients will accept that, and in many cases may actually be happier. There was one of our board members commented that the patient said, I never like it when I see you, meaning the doctor, because that means there's more
Something bad's happening, yeah.
So, I think the interaction and engagement with the patient and, buying into that. And the other, experience I've had with that is talking with some people at Mayo, where they implemented teams. And what's actually communicated to the patient is you are assigned to this team. You're not assigned to a provider, but assigned to this team. And I thought that was interesting and thinking about, because most of us do, I think primary care, at least in the specialty world, a lot of people do identify with sort of their one lead clinician, but if they're assigned to a team instead, and I don't know if that's good or bad,
Yeah, I don't think we know. I think that there is a lot of stuff about, and there's a lot of rhetoric around the team, the patient's the most important part of the team. I think there's some questions about whether the patient actually has the right skill set and can actually play on the team, or whether they're the referee of the team, or exactly what is the patient role in the care process and in the team. I think that's wide open for work to say, what do? You get them sit down and say, what's our goal? And do they share? Do they have task interdependencies? I don't know. I'm not quite sure, but I think it's a whole area of work to think about.
Some of the questions that we've been asking these at 32 institutions we're working with for survivorship was, do you goal set with your patients, right? So your conversation about goals, and several of them have said, oh, that's a good idea.
Yeah, exactly.
Thanks for the suggestion.
Yeah, exactly.
But yeah, then the part of the team, right? When they're setting goals that they're working with you to accomplish something.
Exactly, and I think if you start doing that, you find out that in fact, you assume that their goal is live as long as I can, and maybe it's not. Maybe it's a bunch of other things. So, yeah.
Steve, aren't we saying maybe that this idea of team is really embedded in whether you want to buy off on Ed Wagner's care model, but in a framework like that, you have patient self-management, where you have guidelines that are shared, where you have a clinical information system, you have information. So it's all of a piece. And I think to talk about teams actually goes back to your ecology, the ecology model.
Yeah.
You're going to end up, just what you said, how can I talk about the role if we're not also talking about what are the self-management goals of the patients on our team? Do we have the right people there to help them with that, so forth and so on? So it's really hard not hard, probably we shouldn't separate it.
Right.
Right?
Right. Got to think about the whole context. So the RFA that I have out there, or the PA that's out there, is about multi-level intervention. So thinking about how do you intervene, thinking about the organization, the provider team, and the patient all at once. Don't separate it out. But that comes from clinicians, and it makes PhD researchers really uncomfortable.
Suffer. Well, on that light note,
Yeah.
thank you very much, Steve, for coming
Right.
in. We
My
really
pleasure.
hope the conversation will continue.
Good.